my name is Brenner Macco, and I have a Suresult D3 Ultra handheld ultrasound unit here. And I'd like to use this today just to show you a sort of a quick scan of the shoulder of the rotator cuff tendons. And more specifically, I'll explain the signs you'd be looking for a large supraspinatus tear. Because if you're sort of inexperienced and or you have one of these general purpose probes, it can be difficult to distinguish between a regional tendinosis or tendonitis and the tiny microscopic tear. That can be hard to see. And it is hard to see, even for me. But you know what's really easy to see? A large tear, a large full thickness tear or a full rupture is easy to see in almost any quality of unit. You can't miss it. Or I'm going to explain why you can't miss it. And so if you have a handheld ultrasound unit, you can add ruling out a large supraspinatus tear into your roster of skills. And I'll summarize what we'll be looking for. We're going to be looking for fluid around the biceps tendon. Yes, that could be a tenosynovitis, but that can be fluid just tracking down from a supraspinatus tear from the joint. We can also look at the shape of the supraspinatus tendon. It should have a nice convex shape to it. And if that shape is missing, could be because the tendon's missing. That indicates a full rupture. And you can sometimes see something called the cartilage interface sign. If you have a lot of fluid, where the tendon is, then you'll see a hyperechoic line between that fluid and the cartilage. And because both of those are very dark, they're very hypoechoic. And of course, you may see fiber disruption, that indicates a tear. And you may see cortical disruption, and cortical disruption is also associated with a tear. Although don't be misled, because I've sort of been misled. If you have someone with sort of chronic shoulder problems, tear, healing, tear, healing, tear, healing, the cortex can look all chewed up anyway. And I'll mention one pitfall: don't mistake the subdeltoid bursa as the tendon. The tendon attaches to the superior facet, the bursa goes past. And that bursa can be thickened if someone has a lot of impingement syndrome for months and years. Okay, so we're going to do a very quick scan. I'm going to look at all the rotator cuff tendons. That being said, again, I'm focusing on my clinical question of whether there's a large tear of the supraspinatus tendon. Is that what I expect? Now, I normally do a few orthopedic tests first. I'll do resisted internal rotation, resisted external rotation. That helps me rule in, rule out, infraspinatus, subscapularis. That helps me answer my questions, because the big question I'm going to answer with my unit is whether there's a large tear of the supraspinatus. So I find the orthopedic tests are, again, for a beginner. Use your orthopedic test for the other parts of the rotator cuff. Yes, you can take a look and see if you see something. But particularly the subscapularis can be a little tricky for a beginner. But what's not tricky is, if you follow these guidelines, is seeing if there's a large tear of supraspinatus. So I like to start with the patient seated, and me standing behind the patient. This gives me full access to the front of the shoulder, sort of where the pain typically is. And if I want to, I can very easily move over and scan the other shoulder and use split screen and compare side to side. And the other advantage is you and the patient can both be looking at the screen right in front of you. I'm going to start with the biceps tendon in transverse or short axis. And there it is in the intertrabecular groove, or the bicipital groove. And I could follow it up to the rotator interval, or I could follow it a little bit more distally. What I'm looking for is if there's excess fluid in the tendon sheath, which could indicate a tenosynovitis, or it could be an indirect sign of a rotator cuff tear, in particular that supraspinatus, right? Now, if I center this, and I can rotate to get the tendon in long axis. And there we have it. It looks a little dark. If I heel toe, you see the fibers then brighten. Right? This is the anisotropy artifact. If the fibers are perpendicular to the sound beam, they'll appear bright, and if they're off axis, some of the sound beam reflects and doesn't return. So this is a perfect example of seeing anisotropy and heel toeing the transducer, manipulating the transducer to minimize anisotropy. So I'll go back to transverse instead of long axis, and I'll ask the patient to rotate their arm outwards. And this gives me access to look at the subscapularis tendon. I can have her rotate back to neutral. Now, if I'm looking for impingement syndrome, I can park over the acromion, and I can ask her to lift her arm towards the side and back down. Now, in order to get a good look at the tendon, I like to have the patient in the modified Cras position. this sort of pulls the tendon in front. It gives you more access to the supraspinatus tendon. So if you're, yep, that's the position. So in which case long axis will be about in this plane. And we can see it has that bird's beak appearance. We don't see the double contour sign. We don't see cortical changes here. We see that nice convex appearance of the tendon, and it has normal echogenicity. The footprint looks a little bit dark, but that's from anisotropy. If you heel toe the transducer, it fills in. And of course, I can screen more anterior and more posterior. I can screen through the tendon, and I can switch to short axis, and I can screen through that tendon in short axis as well. Okay, now I have the patient go back to neutral. Now, for something like the infraspinatus, there's debate as to whether you should have it stretched or not, or more neutral. I prefer more neutral because the tendon is basically more straighter, whereas if you have it stretched out, it's around a curved surface. It's a little bit trickier to scan. So I have her in neutral, and I'll take a quick look at the infraspinatus tendon. And of course, I could add in teres minor, but that's rarely injured. And I could, of course, screen through the muscle because an abnormally hypoechoic muscle could indicate one of those myofascial trigger points. And so I do see a little area that's a little bit more hypoechoic right there. And I'll see if this is a myofascial trigger point. I'll apply pressure there for the patient. Is this tender? Yeah. Do you feel that pain travel anywhere, or does it just stay underneath my thumb? Okay, and sometimes you'll find these and it'll be the cause of her pain. Now, she didn't have any pain to begin with, so I wasn't expecting to find one of those nasty myofascial trigger points with the referred pain. But that's what you could do for those myofascial trigger points. You can actually use imaging to find them, but of course you could also just palpate for them. And that's my scan. Suresult would like me to say that if you're interested in one of their units, that they do their best in terms of the duties and taxes and shipping and getting it out to you in a timely fashion. And if you have any questions, just contact them through WhatsApp, and they've always been very responsive with me.